served as a lieutenant commander and a staff neurosurgeon at the Naval Medical Center, San Diego. And also he was after that deployed by the NATO to the multinational medical hospital in Kandahar, Afghanistan, where he served there during 2010 and 2011. He's been awarded multiple medals for his great services, such as the Afghanistan Campaign Medal, the NATO Medal, among others. He was honorably discharged from active duty service and completed after that his endovascular neurosurgery fellowship at the Barrow Neurological Institute in Phoenix. After that, Dr. Park joined the neurosurgery faculty at the University of Utah, where he was the director and the founder of the Endovascular Neurosurgery Fellowship and Associated Residency Program Director of Neurosurgery. He was then recruited to the Department of Neurosurgery at UVA, and since then he's been working there. He was selected by the residents to receive the inaugural department faculty mentorship and the teaching award, and also received the patient experience award in 2021. Dr. Park is a recognized leader in the field of endovascular neurosurgery with over 250 peer-reviewed publications, as well as book chapters, most famous being as the lead editor of the seminal textbook, Flow Diversion of Cerebral Aneurysm, as well as evidence-based decision-making in neurointerventional surgery and carotid artery disease. Also, Dr. Park helped lead UVA Health to the highest distinction as an alliance to cure cavernous malformation center of excellence for its care for cerebral cavernous malformation. We're excited today for his talk about dural arteriovenous fistula, the good, the bad, and the ugly. Please join me in welcoming Dr. Park. Welcome, Dr. Park, and
thank you very much. It's an absolute honor to be here presenting at the Seattle Science Foundation TV. I had the great fortune of training under Dr. Cameron McDougall, and so I kind of feel like I'm bringing coals to Newcastle discussing dural arteriovenous fistulas with somebody I consider to be the master in attendance. So disclosures, I don't have many. I'm on the clinical events committee for the Medtronic Elevate study, and I'm an investor in Von Vascular. So we'll go through an introduction, which I think many of you will already know concerning dural arteriovenous fistulas, as well as some treatment strategies and illustrative cases.
Park,
and the reason,
screen?
I'm sorry?
Did you share your screen?
Oh, is my screen not shared? Sorry.
I can't see anything. Thank you.
Okay, is that better?
I don't see it yet.
Yeah, we can't see it yet.
Oh,
there we go. Starting.
Yeah, we can see it.
All right, so I glossed over the disclosure slide, but here it is. So I've always thought these were some of the most complex lesions to try and understand, just given how variable the anatomy is. And it does really require a lot of study to figure out what's the best ways to treat dural arteriovenous fistulas, even just how to describe them. And oftentimes I found myself struggling to figure out what's the best treatment options. I would see these presentations and also watch Dr. McDougall do some very elegant treatments for the dural AV fistulas. And I found that early on in my training or early on in my practice, it was a little bit more scattershot. And sooner or later, I got to the correct answer, but oftentimes it was a little bit of a roundabout treatment plan. So this is kind of a journey through that as well. As we know, dural AV fistulas, they develop over time between the arteries and veins near the brain. They're a rare form of a vascular malformation, only comprising 10 to 15% of all intracranial AVMs. And they are predominantly in the female gender with a preponderance of 61 to 66%. There's several theories as to why they develop. The thought is that there's a thrombosis within the sinus, and the brain tries to develop extra drainage channels, and they go through these dormant embryonic dural AV channels in the to help with venous outflow. It's also thought that venous hypertension or thrombosis can promote the local angiogenesis and help form these dural AV fistulas. Or it could be more of the chicken and the egg, where the dural arteriovenous fistula arises first and then results in the venous occlusion. So there is some controversy, and it's probably a combination of factors that leads to their development over time. Most commonly, they're in the transverse sigmoid sinus junction, but they can be found throughout the intracranial vault. Less commonly, the superior inferior petrosal sinuses or the superior inferior sagittal sinus or any other dural-based venous structure. They generally arise from external carotid artery branches. That's the most common vascular supply you'll see to the dural AV fistula. The middle meningeal artery is one of the most common and is a great route for treatment of the dural AV fistulas. But they can also develop from branches arising off the occipital artery, traveling in a transcranial fashion, and other branches such as the posterior auricular artery and the ascending pharyngeal artery. But they can arise from branches of the vertebral as well as the internal carotid artery. Sometimes they're asymptomatic. They can be found incidentally. Oftentimes, patients will complain of a pulsatile tinnitus, especially when they're involving the transverse sigmoid sinus. Patients oftentimes complain of headaches, which can lead to the pickup of them if they're particularly large on non-invasive imaging. And you can often, on physical exam, hear a bruit for some of the larger ones. Depending on the size, it can also develop other problems such as compressive neuropathies when venous varices form and impinge on cranial nerves. Most damaging is when it results in an intracranial hemorrhage. And oftentimes it can be a multi-compartment hemorrhage versus other types of hemorrhages like an aneurysm, which is predominantly subarachnoid or arteriovenous malformation. As part of the workup in non-invasive imaging, they can be invisible. Sometimes they're not seen very well. But CT angiograms or MRIs and MRAs, they can provide valuable information that could lead one to suspect the presence of a dural arteriovenous fistula. But still, digital subtraction angiography is what we use predominantly to identify a dural AV fistula, but also to characterize it and figure out exactly what the arterial supply to the fistula is and what the venous outflow is, because that makes a very big importance in terms of what the management plans are for these lesions. There are two well-recognized classification systems for dural arteriovenous fistulas. One of them is the Conard classification, which was originally published in 1995. And this is a diagram from the original description in the manuscript. And as you can see, they can be very complex. And in this description, it's mostly describing the dural AV fistulas that arise around the sigmoid transverse sinuses. This is a more complicated classification system. It is divided into 5 types with various subtypes, really depending on its anatomical structure. The type 1s confined to the sinus with anterograde flow within the sinus without cortical venous drainage, and the type 2A, which are dural arteriovenous fistulas confined to the sinus. There's retrograde flow within the sinus, but no cortical venous drainage. These are generally considered to be the low risk types. The type 2B and greater are the ones that that we are most concerned about, and that's due to the retrograde cortical venous drainage. All those from type 2B on, that is a classic feature of the dural arteriovenous fistulas. So, and at the same time, Jonathan Borden published his classification for spinal and cranial dural arteriovenous fistulas in the Journal of Neurosurgery. And again, he had a classification system that was actually simpler and divided into 3 different categories. This is actually from the original publication in the Journal of Neurosurgery. And it's actually really interesting to go back and look at some of the seminal manuscripts that have been published in our field, because these are just absolutely beautiful illustrations that were done and even printed in color in the Journal of Neurosurgery in 1995. But you can see that his 3 main classifications of type 1, type 2, and type 3 dural AV fistulas, again, very similar, and they mirror the Conard classification system. Type 1 fistulas drain into the dural venous sinuses. Type 2 involve retrograde cortical venous drainage, and type 3 is a more complex version of type 2, and you can see the correlates with the Conard classification system. You know, the important thing is, what do we do with these classifications? Is there any useful information that the classification system can help us in management of these patients? And there is actually a very clear delineation with both the Conard and Borden classifications, with the Conard 1 and 2A, which correlates with the Borden 1 having a benign course. These are dural AV fistulas, which may be symptomatic from generally pulsatile tinnitus, maybe headaches, but these can be managed conservatively. And when I have patients that have these lesions, and oftentimes they come as a referral from our neurootology group during the workup of pulsatile tinnitus, you can reassure the patients that these tend to have a benign course, or very often have a benign course, with low risks of any untoward events happening. However, anything above that, and again, it is really predicated on the cortical venous drainage system, those will have a more aggressive course. And you can see the annual risk of hemorrhage, 8.1%, annual combined mortality rate of approximately 10% following hemorrhage. So anything that has evidence of cortical retrograde venous drainage, we consider to be aggressive, and these are the ones that we would definitely institute therapy for. Additionally, some locations are thought to be more aggressive in their natural history. The dural arteriovenous fistula is localized to the tentorium, the middle fossa sylvian, as well as the anterior ethmoidal, which almost always have cortical retrograde venous drainage. So for low-risk dural arteriovenous fistulas, they can just be observed. There's also reports of manual compression therapy, the 20 to 30% cure rate. There is some thought that this might just be emulating the natural history of these low-risk lesions. And for manual compression therapy, what the patients are instructed to do is take, if the dural AV fistula is on the left side, they take their right hand and compress their carotid artery for brief periods of time, repeatedly throughout the day. And the reason people use the contralateral arm, or the recommendation is for the contralateral arm, is that if you unfortunately induce an ischemic event, hopefully your arm will fall off your carotid artery. But again, there is an incidence of success with that type of treatment. And again, sometimes natural history, they will take care of themselves. When I have patients like this that present with pulsatile tinnitus, the number one question I ask them is how disabling is the symptom, and oftentimes I'll encourage them that if they're able to live with it, if it just becomes background white noise, it doesn't affect their quality of life, doesn't lead to poor work or school performance, and they're able to sleep at night, that absolutely reasonable not to treat this. And a lot of patients will elect not to have any treatments. However, if it becomes more disabling, and you'll oftentimes hear the story that says they can't concentrate at work meetings, their work performance is suffering, it's driving them crazy, they want to they become very irritable, they can't sleep at nights, then it's reasonable to offer them treatment for low risk dural arteriovenous fistulas. As far as treatment, endovascular embolization is the first line treatment in this day and age. With the advent of newer embolic agents, and they're not so new anymore, endovascular embolization really took off. You can go transarterial route, generally using liquid embolic agents, because it's oftentimes very difficult to get microcatheters to the fistulous point, which is a requirement to treat the lesion successfully. Otherwise, they will recur. Even though the angiogram may look satisfactory, and that fistula might be occluded, it might appear to be occluded over time. If the fistulous point is not occluded, it will recruit newer branches that you can't visualize on that immediate postoperative, post-treatment images, and then it'll lead to a recurrence. And oftentimes that becomes more difficult because you've used up the main and primary channel, the one vessel that provides the easiest access to the fistulous point. A transvenous occlusion of the fistulous pouch is also an excellent option. This is one historically, before liquid embolic agents were popular. This was the primary endovascular treatment. You would navigate into the venous side and proceed with coil occlusion of the sac, which would lead to thrombosis of the fistula. You can also use liquid embolic agents in a transvenous fashion as well, or a combination thereof, to address the fistulas. And these endovascular embolization as a primary treatment have been very successful in the reported literature and in my practice. Surgery is a oftentimes much more daunting process depending on the type of fistula. Ultimately, there's multiple steps that can be undertaken during the course of treatment for dural arteriovenous fistulas. Definitely want to excise the fistula. It may require complete skeletonization of the sinus depending on where the dural AV fistula is, such as in a transverse sigmoid sinus. You need to take the dura both in the supratentorial and infratentorial compartment, as well as the tentorium, to fully isolate the sinus and cure dural AV fistula. Can disconnect the cortical venous drainage system to hopefully relieve that negative aspect of it, and in addition to ligation of the fistulous point. Sometimes you can do an open packing of the sinus, which is much more rare, as we're oftentimes successful just going with the transvenous coil occlusion embolization. But depending on the location, they can be an excellent primary treatment as well. Anterior ethmoidal fistulas, in my practice, I will offer surgery as a first-line treatment versus embolization. There are more and more reports and experience with navigation through the ophthalmic artery and successful embolization of these ethmoidal fistulas. In that regard, I do, even though it is reported to be pretty safe with minimal risk to vision, I'm still somewhat reluctant to proceed with that as a first-line treatment when the surgery is pretty straightforward in an appropriately selected individual. Likewise, tentorial dural AV fistulas can be very elegant procedures, and oftentimes more direct and straightforward compared to embolization. Radiosurgery is also used as a treatment, but oftentimes it's for patients who might not be great candidates for either embolization or surgery. They do have fairly good success rates, with a recent series reporting a 68.6% complete occlusion, or I'm sorry, recent meta-analysis reporting a 68.6% complete occlusion, 97% symptom improvement, and a cure rate of 78%. That is, these are radiosurgery is more effective for dural AV fistulas not involving the cavernous sinus, as well as lower risk, lower grade dural AV fistulas. The higher grade with cortical venous drainage tend to have worse results with radiosurgery and incomplete treatments. Based upon that, some of the guidelines and recommendations developed for radiosurgery for dural AV fistulas, as you can see in terms of the patient selection, it's still those who are generally high risk for either an incomplete occlusion with embolization or a high risk for surgery, in which case then radiosurgery becomes more of an option. Also, you can do radiosurgery following embolization or other treatments that have left a residual dural AV fistula. That's generally how I practice. I am fortunate to have one of the world-renowned stereotactic radiosurgery experts in my department, and I will recruit him to help with the particularly difficult ones where ultimately I'm unsuccessful in curing high-risk dural AV fistulas. He's been very good at planning for radiosurgery, and we've had very good success of him taking care of residual lesions that were ultimately incompletely treated with other means. So for those that you are considering treatment, again, surgery, radiosurgery, embolization, this is pretty much the algorithm that I'll use. Embolization is number one for the general run-of-the-mill dural AV fistulas. And if I'm able to cure it, then we're done with that, and the patient can hopefully go on to lead a great productive life with a follow-up angiogram within 6 months to a year, just to confirm that the treatment has been durable. If the embolization is incomplete, then we'll look at other alternative options. And I tend to choose radiosurgery over surgery for residuals as long as they're not high risk. So the dural AV fistulas, which we think are very straightforward, even though their presentations can be a little bit challenging. This was an patient that was that presented with headaches, and on the non-invasive imaging, it was described as an arteriovenous malformation with intranidal aneurysms and drainage through the ophthalmic vein, supraophthalmic vein. And as you can see on the MRI scan and on the CTA reconstructions, this is a somewhat complex lesion. It seems to be centered right at the ICA bifurcation with distinct aneurysms, intranidal aneurysms. However, when we did the angiogram, we noticed is that there was filling of a dural AV fistula from the anterior ethmoidal. So it was very interesting anatomy in that regard. The left ICA delayed injection, you can see that those aneurysms were venous varices, and with a rather unusual drainage pattern, whereas most dural AV fistulas will just drain superiorly into the frontal lobe. This one tended to drain posteriorly. It was predominantly fed from the right external carotid artery, and looking at the drainage system and on the CTA, appeared to be a very straightforward anterior ethmoidal fistula with a little bit of an unusual drainage pattern. So looking at the treatment options, the embolization, surgical ligation, or radiosurgery. I felt that because of the anatomy and the arterial supply, rather than trying to go in either through the external carotid artery branches or the ophthalmic artery, that this was much more straightforward as a surgical case. These are not my operative photos. I borrowed these from the Barrow Neurological Institute YouTube channel, but this is basically what anterior ethmoidal dural AV fistulas look like. It's a standard craniotomy, a smaller craniotomy just centered low in the anterior cranial fossa. And as you lift the frontal lobes up slightly, you can follow the anterior cranial fossa, where you'll generally see the anterior ethmoidal fistula as an arterialized vein rising from the cribriform plate. And you just coagulate and clip, and can have pretty good results. This is the CT scan, CTA immediately following the treatment, paired with the MRI scans. I was a little bit concerned, at first everything looked great. Fistula is disconnected, intraop angiography, get the delayed CT angiogram, you still see the venous varix fill. So I was a little bit concerned that maybe I had missed the fistula, or there was another channel that I didn't see. But on the formal follow-up angiogram, it confirmed that we successfully ligated the fistula. So this is a pretty straightforward case, and with a high success rate, low surgical complication rate, and patient went home, a couple days after the procedure. Sometimes it gets more challenging for a number of reasons. Access can be a complicated thing. This was a younger gentleman who had a dural AV fistula with corticovenous drainage. And you can see the middle meningeal artery is nice and hypertrophied, and one of the feeders along with the occipital artery to a pretty classic looking Borden-II dural AV fistula. However, right where the red circle is a little bit tortuous with microcatheter navigation. And treatment options, again, embolization, surgical ligation, or radiosurgery. This is a high-risk fistula. And I thought that we would have success. We had two very good routes, either through the transarterial routes, through the occipital artery, or through the middle meningeal artery. Initially tried the occipital artery, felt that it got pretty close to the fistula. There was large transmastoid arteries to the fistula, so got distal, and was able to occlude the branches off the occipital artery, but the fistula still persisted. However, because of that previous tortuosity in the middle meningeal artery, I ended up dissecting that vessel and shutting it down, so I lost my route into the middle meningeal artery. If I felt pretty confident if I was able to get that microcatheter all the way out to that fistula's point, I'd have a very nice chance of success through an embolization. So unfortunately, there was following the initial embolization attempts, I was unsuccessful. So then the question remains in this high-risk fistula: do you do surgery or do you do radiosurgery? I think actually either of these would have been very good treatments for this. Radiosurgery, one of the issues is that it is more of a delayed cure. It can take several years before the fistula occludes, and again, during that time interval, there's 8% per year rate of hemorrhage, which is not insignificant when you think about it. Whereas surgery would generally be pretty straightforward. It seemed to be localized to one area, the transverse sinus, and fairly straightforward surgery to skeletonize that and ligate the dural AV fistula. But in order to be more complex, I thought, well, the middle meningeal artery, just distal to that tortuosity, the hairpin turns in the initial part, would be an amazing access point to embolize. I just couldn't get there through the traditional transarterial routes. And so I started thinking, well, what if I were able to place a microcatheter directly into the middle meningeal artery, distal to the tortuosity, and then just proceed with embolization. Probably took a straightforward surgical case and made it much more complicated with my thought process. But we have the good fortune to have an intraoperative biplane unit. And I thought that this would be something that we could use our hybrid vascular suite for. So this was a much larger undertaking than I had initially predicted. You can see in this instance, we had to prepare for the craniotomy with the patient's head turned, placed in pins. He was in the lateral decubitus position, placed to access prior to the procedure so that in case we needed to do intra-op angiography, we would be ready for it from the femoral route. Does take a lot of marshaling of resources. Number one, you need a suite capable of performing procedures like that. It involves 2 teams, our standard OR team, the circulatory nurse and operating scrub, needs specific equipment such as radiolucent frames, the microsurgical instruments. You also need your interventional neuro IR team with a radiology technician there, and then the equipment necessary for interventional procedures, access catheters, wires, embolic agents, and fluoroscopy. And our suite is not directly in the neurointerventional space, so it's 1 floor above. So all of the neuro IR equipment had to be brought up. So it does take a lot of marshaling of resources and coordination to find time and to do what you can to make this successful. Initial steps, it starts with the surgical procedure, the intubation, arterial access for monitoring. You perform the craniotomy, and then you identify the middle meningeal artery, and then it switches over to the interventional procedure. In our room, we have to rotate the table 90 degrees into the biplane equipment, which is then brought in, and we perform the microcatheter angiography and the embolization. And then once we're convinced that we've been successful, we return to the surgical position for the closure. So again, like I said, in terms of planning, in the upper left, this was the craniotomy site. That dot indicates where we could easily localize the prior onyx cast right at the fistula site. I had planned, if ultimately I was unsuccessful with this, to just proceed with a direct surgical ligation, which would again involve skeletonization of the sinus. So the craniotomy flap was designed incorporating what I felt would be the cardiac pathway of the middle meningeal artery, as well as accounting for any planned surgery. So it's a little bit of an unusual approach. The yellow line indicates the actual incision that was used for the direct access embolization. So the bottom left, you can see it was a little bit high in terms of targeting, but we were fortunately able to identify the middle meningeal artery, which we did not violate during our mini craniotomy. Small little, let's say about a quarter size, maybe a little bit bigger craniotomy that allowed us to identify the middle meningeal artery, take a little scalpel and just cut right into the middle meningeal artery as it's bleeding. We thread in microcatheter directly into the artery, and I basically free floated it down until I found resistance. Again, I thought I was on a pretty straight edge of the middle meningeal artery, so it was fairly straightforward threading it. The most difficult thing was actually securing it in place, because it had a tendency to back out because there's nothing really retaining it. So you can see I used a lot of 4-0 Neurolon sutures to secure the microcatheter at the site of the entry into the middle meningeal artery as well as to the dura just to secure it. And then I stapled it on multiple points on our field just because there was going to be significant movement, and I did not want the catheters to get pulled out as we rotated the patient back into our biplane suite. So in the top central, that's the preoperative angiogram with the middle meningeal artery. That middle image is the microcatheter angiogram, and you can see that we're pretty distal within that middle meningeal artery right before that bifurcation. I felt pretty comfortable using this as the site of the embolization. We prepared the microcatheters in the standard fashion with DMSO and Onyx, and it was a pretty short procedure given how close we were. And the Onyx penetrated very well. The bottom center image is the Onyx cast, and the follow-up angiograms intra-op demonstrated occlusion of the fistula. So we felt comfortable that we had succeeded in our objective with a small little craniotomy rather than a larger skeletonization. And you can see the subtracted Onyx cast there. He's outlining wonderfully right at the fistulus point. And he went home the next day. One of the cool things to see is that once we finished, there was still reflux around the microcatheter, and the Onyx actually refluxed out onto the dura as well. So there was a little puddle of Onyx at the conclusion of our procedure, but that was easily wiped away. And then we ligated the proximal part of the middle meningeal artery just to make sure that there wasn't any untoward events from that. Another example of using a combined surgical endovascular approach. Again, endovascular access was an issue. This was a complex, a high-risk dural AV fistula, predominantly fed from the left external carotid artery branches, middle meningeal and occipital primarily. And you can see how that vascular plexus of the arterial supply is really very small branches. And I felt that that was going to be a pretty significant challenge to try and proceed with transarterial embolization. And this was an isolated sinus. The left internal carotid artery drained through the contralateral side and a large occipital venous sinus as well. So I felt confident that that transverse sinus was a great candidate for a transvenous occlusion. And you can see also this is a significant fistula, and the right external carotid artery had collaterals towards the fistula side as well. So again, I think transvenous embolization would be a straight shot for this treatment. Unfortunately, it was a little bit more challenging than that. I struggled greatly to get into that left transverse sinus. You can see on these transradial angiograms, there's a robust drainage from the right side, the normal side, but on the left side, it was actually more of a plexiform arcade of vessels, and it was incredibly difficult, and I was unable to navigate into the fistula from the transfemoral route, transvenous transfemoral route. I went up through the right to see if I could find a passage to the left side and was unsuccessful. And from that left CCA angiogram, again, you can see that there's maybe tiny channels, but nothing that I could successfully navigate into. And again, this is a stricture point that was really inhibiting my navigation. So I thought, well, another option, why don't I bypass that complex arcade of veins in the proximal neck and just go more distal and access the jugular vein and directly feed a microcatheter straight into the fistula, into the venous pouch. This was very straightforward, identifying the jugular vein through standard approach, a small several centimeter incision in the neck. Once it was isolated, able to enter it just as you would with any vascular access with a little needle, wire exchange for a sheath. and secured that in place. And at the conclusion of the case, you just remove it and place a vascular clip, and patient has a minimal surgery to allow you to access the venous pouch. And here, this is the microcatheter with an angiogram demonstrating the retrograde cortical venous drainage, proceeded with embolization all the way out to where the sinus started, and a combination of coils and onyx was able to include the fistula and remove the dangerous cortical venous drainage. The part that was down lower was still patent, and unfortunately we had actually run out of coils, but elected just to watch this. The patient's done very well without any cortical venous drainage, which again is the primary fear when it comes to risk of rupture. And sometimes they're incredibly challenging. This is actually a case that Dr. McDougall is aware of as well. This is a baby that was born and underwent multiple rounds of embolization for a vena Galen, or it's hard to say. I wasn't unable to get the records from there, but ultimately it was an incredibly challenging arteriovenous fistula. You can see there is a large onyx cast within the region of the torcula. And on the right-hand image, you can see the cortical venous drainage. Everything, the sinuses had been completely occluded, and the young boy was draining everything through the brain. It's a pretty terrible situation, and he was very symptomatic from that, becoming very lethargic, unable to go to school, was losing vision. Here again is another MRI scan demonstrating that venous engorgement through the posterior fossa, where all of the vast majority of his drainage was coming through. These are all just veins that are trying to drain the blood flow from his supratentorial space. It was an absolute mess when it was presented to us, and you can see visualization is incredibly difficult. Whatever this large channel near the torcula was is completely filled with coils and onyx, multiple surgical clips from his numerous procedures. I think all told, he probably had at least 6 surgical treatments, along with dozens of endovascular attempts at treatment. And we added to this, trying to take any transarterial feeders that we could. The primary transarterial feeders were already sacrificed during his multiple prior treatments before he presented with us. And looking at the vertebral artery angiograms, you can see that the vascular supply to this fistula is incredibly complex, to the point where it was almost impossible for me to identify where the direct connections were, given the complexity as well as the artifact from the prior treatments. One thing I was able to identify is in these vertebral artery angiograms, they were the abnormal feeders for the fistula was entering into that larger venous pouch right in there, and also inferior to that. Superior to that was cortical venous drainage, where I think you can see my mouse, hopefully. This was a cortical vein that was feeding into the sinus and then draining out these sinuses. So it was a difficult situation, but I thought that if I could separate this pouch and anything proximal to that, might make a big difference in terms of shutting down this fistula. But there was no way to access that from our traditional standpoint. So looking at the angiograms, I thought, well, I actually can access the anterior third of the superior sagittal sinus and potentially thread a microcatheter distally. And we ended up doing that procedure, the small craniotomy directly over the anterior third of the superior sagittal sinus. This is a very rudimentary picture using a handheld iPhone. And you can see the micropuncture set aimed posteriorly into the sinus with the micro wire. And you can see that's a bright red blood from the fistula rather than venous blood. So following that with the micro wire in, replaced it with a small sheath and an angiocath, and then threaded the microcatheter back to where the posterior sagittal sinus was located. And as you can see in that middle panel, we were able to thread the microcatheter down past that pouch and coil all the way up to that pouch, preserving that large draining vein, that large cortical vein. And did a very good job of disconnecting and occluding a lot of the fistula from the posterior cerebral arteries. Patient actually ended up doing very well at the time. He was incredibly lethargic, unable to go to school, was bedbound, and since then we've had close follow-up, and he is enjoying life and able to participate in all his activities. So that, despite an incredibly arduous challenge by multiple providers over the entire course of his lifetime, he's actually been doing very well since that last treatment. You can see we've done a handful of these direct access cases. They're not very common. They're hard to find. And actually, thankfully, it's oftentimes a lot easier and effective going through direct either transarterial or transfemoral routes in the traditional fashion. But every once in a while, we'll run across something where a hybrid OR room becomes invaluable. In conclusion, these are complex vascular malformations. I'm not sure I thoroughly understand them, and it seems like I learn something new every time I run across one. You can treat the benign ones expectantly. The more aggressive early fistulas, they should be treated by one means or another. And I will tell patients that they may require staged procedures, embolization procedures, or radiosurgery or surgery if we're ultimately unsuccessful treating those aggressive ones. But in conclusion, thank you very much. I very much appreciated the opportunity to talk, and happy to entertain any questions.
Thank you so much, Dr. Park. I'll open the floor to our faculty for comments.
Yeah, that was great. I mean, and I'm so grateful for that last case, and obviously have thought about him a lot over time, and glad to hear that he's continuing to do well. That was really a pretty amazing situation.
Yeah, I actually that case, I was fortunate to have Dr. McDougall locally, just up the road at Hopkins, and I strongly encouraged the mom to see Cameron, to say, I'm almost at my wit's end here. I need some help. And Cameron's like, it said, actually, I think you're exactly where you need to be, and keep plugging away at it.
No, I had a beautiful drive down the Shenandoah Valley. I got to watch a nice case. I didn't get my hands dirty, and a good outcome. It was the ideal situation. Yeah, no, I mean, that case really is one that sort of just is illustrative of just how amazing these cases can be, and how the body's ability to create fistulas is stronger than our ability to find and plug them. So it really does show just how committed you have to be to manage some of these when they really go sideways, especially in the young children, where they're presumably creating all kinds of VEGF or whatever it is that creates them.
Yeah.
Yeah.
Yeah, I'm still waiting for the other shoe to drop because it's not cured, but he's doing incredibly well, and I'm gonna just leave well enough alone for the time being.
Yeah, yeah. I remember one other young child that was similar to that from Phoenix, and the poor boy had very similar fistulas everywhere, and he had huge macrocephalus, and you may even have been there for one of his treatments. He had multiple treatments, but we had difficulty getting his head under the image intensifiers. His head was so huge, and
Oh wow.
he was this kind of smart kid, and we kind of tweaked him along for a number of years, and I think they kind of burn out a little bit, that they stop creating new ones, and if you can just get the balance to where they're not, having tremendous venous hypertension, that they'll eventually sort of can hit a equilibrium where they can function. So hopefully, fingers crossed, your boy will hang in there. Steve, please.
Thanks, man. That was a great talk. Really enjoyed that. And nice to see the hybrid room is still running hot. It was just getting installed when I was a resident, so glad to see it's still working. A couple of questions, or a question about radiosurgery. In terms of the targeting, we found you can get a pretty good dose to these because typically they're in that transverse sigmoid junction. You're mostly targeting pretty close to the skull, and there's not a lot of brain that's getting a lot of dose. Can you go through your algorithm for how you do your targeting? Do you use MRA? Do you use angio? Do you put them in the frame? Or do you just target off the MR? And do you target on the images that are pre your kind of original embolization, perhaps? Or do you target when there's all that onyx in the way and you're not really sure where the residual fistulas sometimes, or how do you do your targeting for residual fistulas with Gamma knife?
Well, I will. Thanks for the question, Steve. I will say that the practice patterns as far as radiosurgery here at UVA have not changed. I do the angiogram for my partner, who does the Gamma knife radiosurgery, but he will target off of angiograms and the frame, and still traditionally believes that's the best route. And I think part of it too is we use the most recent angiogram. So if there is a lot of artifact, and it does complicate kind of the management, because he'll look at the films of our post-embolization and say, you know what, there's not enough for me to be able to target. I can't see the vessels clearly enough. So that does become a challenge. It might be just as they are doing now with potentially Gamma knife radiosurgery for AVMs followed by embolization. Maybe that's a route that this could ultimately take. But I think we're pretty successful with the embolization, so that it's not a huge part of our practice. And fortunately, I don't have to shunt as many patients off to him as a salvage treatment, given how effective embolization is. So we're I guess a little bit more traditional in that sense, that almost all of our Gamma knife for vascular lesions is based off framed angiograms. Thanks.
Yes, I sometimes think for those cases that young boy has had a million procedures, would some radiation help? But it's always tricky to pull the trigger on, especially with children. We can get a pretty good dose in there without too much trouble. I wonder if sometimes on those highly recurrent cases whether it would be helpful, but I don't think we have enough numbers to answer those questions.
Right. And I did ask Jason if he was willing to take a swing at this one. He politely declined.
He's always had good judgment, Jason.
Yes, absolutely.
Thank you.
Thank you.
We have one question in the chat. It's about the last case, Dr. Park. Is there any role for superior sagittal sinus ligation in the anterior third, of course?
I don't know if the anterior third, I mean, where the fistula was is in that posterior third. And obviously, when you saw that mass of onyx and coils, that was the issue. If you were going to disconnect something, I thought disconnecting all of those posterior cerebral artery fistulous feeders was the goal. That's why I presented that way. I don't think including the anterior third really would have done anything because the drainage was through trolard and all the cerebral veins along that middle third of the sinus. And I think it could have gone to that posterior third and potentially ligated that surgically, but I thought that was going to be a much larger procedure. That onyx cast and the coils, I had at one point attempted to say, well, maybe if I just resect that, we'll have an idea. That was an ill-fated surgery that I did because it was just a ball of concrete and I could not get around it. I isolated it as best as I could and like around it, but there was just no way to resect it. So I thought if I were to go back in there and try and ligate that posterior third right before that cortical vein that I had outlined, I thought that would be something I was not looking forward to. And if I could figure out a way to do this endovascularly, it would be a lot easier for me and hopefully safer for him. And I was very fortunate, maybe lucky to be able to pull that off.
Thank you.
Yeah, I think it's always is kind of that inverse law of the farther you are from the key point, the lower your chance of cure, whether you're coming arterial or venous or open surgery or radiosurgery. The whole trick to these is understanding the key point, and occasionally there's a couple where there's multiple fistulas, but most of the time it's one key point, and you've just got to identify that key point, typically on the earliest arterial phase, the first time you see the vein, and then work from there and figure out, just being a lazy person, what's the easiest way to get there. And the easiest way to get there is the safest, and it may be with a catheter, it may be transarterial, it may be transvenous, it may be open surgery, it may be radiosurgery, but just find that point. The closer you are to that point, the higher your chance for cure, and take the easiest path there.
Yeah, I remember one case from training where we had Dural fistula and I couldn't make heads or tails of it. And Cameron said, oh, here's a little side pouch. That's what we need to occlude. We went transvenous. I think it might have been like 3 or 4 coils, a tiny little coil mass. Next angiogram, the entire thing had shut down. And I was absolutely in awe. I was thinking this was just going to be multiple arterial embolizations and sac the sinus, and it's tiny little sausage of a fistulous pouch that Cameron had identified, and it can be incredibly elegant procedure.
Yeah, no, it's magical when that's what keeps us coming back and accepting these really awful cases, because that's somewhere in there's those little pearls of these beautiful cases where it's just just so sweet and so simple.
Yeah.
All right, I think we're at time, and greatly appreciate seeing you here today. I look forward to seeing you in about 6 weeks.
Oh, absolutely. It's the highlight of my year coming up.
Yeah, it should be fun. So stay well, and we'll see you then.
Yeah, thank you again.